Welcome to Weekly Neurology Deep Dive. This week we're going to be digging into a recent meta-analysis that's been causing quite a stir, I think it's safe to say.
It certainly
It
has.
looks at endovascular therapy. We all know that as EVT, of course, compared to best medical treatment, BMT, for acute ischemic stroke patients, specifically those with distal medium vessel occlusion, DMVO.
Right.
And as always with our deep dives, this is purely for educational purposes. We're going to give you an overview, but you really need to read the full paper to get the whole picture. This is not a substitute for good clinical judgment.
Definitely. And I think this is a really important topic for neurologists because this whole area of DMVO treatment, the evidence is changing so rapidly. This meta-analysis gives us some really valuable insights that can really help us in our day-to-day practice.
So before we dive into the study itself, let's take a step back for a second. Can you maybe explain why DMVOs are so tricky to treat in the first place?
Yeah, DMVOs, they're a challenge. You see, they involve blockages in those smaller vessels further away from the heart. So it's a lot harder to reach those occlusions with catheters and all those devices compared to the larger vessel occlusions.
Oh, I see.
And because of that, the role of EVT in DMVOs has been, well, it's been a bit of a debate in neurology for a while now.
So this meta-analysis was trying to bring some clarity to that debate, to that gray area. Can you tell us a little bit about the research itself, the scope of it?
Sure, this meta-analysis pulled together data from 31 studies, and these were published up to December of 2023.
Oh, very recent.
It is, and it included a total of 6,826 patients.
Wow.
So a pretty good sample size. That gives us a lot of data to work with. But it's worth pointing out that most of these studies were retrospective, and that has, some limitations that we'll get into a little later.
Okay. So you mentioned this meta-analysis has been stirring up a lot of conversation. What were some of the findings that you found most surprising or maybe even unexpected?
I'd say one of the most striking findings was that EVT didn't really move the needle on functional outcomes compared to BMT for patients with DMVO. This was true for functional independence. We measure that using the modified Rankin Scale score, MRS, of 0 to 2 at 90 days, and for those excellent functional outcomes, an MRS of 0 to 1.
Now, just as a reminder for our listeners, functional independence means the patient can handle those daily activities like getting dressed, moving around their home, making a meal, all without needing help.
Exactly.
So for neurologists out there who are thinking about EVT for their DMVO patients, this suggests it may not be the magic bullet for functional improvement that we'd work for, especially considering how well it works for large vessel occlusions.
That's right. It challenges the idea that EVT would be equally effective across the board for all stroke subtypes. It really highlights the need to be much more careful about how we make treatment decisions for patients with DMVO. We can't just focus on reperfusion rates alone.
And that leads us to the other big issue, the safety of EVT. Did the meta-analysis raise any red flags about adverse events?
Well, while it didn't show a clear advantage for EVT in those functional outcomes, there was a significant concern about safety. EVT was linked to a much higher risk of symptomatic intracranial hemorrhage, we call that SIPS, compared to BMT.
Okay.
The numbers were 5.5% in the EVT group versus 1.9% in the BMT group.
So that's a pretty big difference in sub-risk.
It is.
This is crucial information for neurologists when they're having those conversations with patients about their treatment options. Being able to actually put a number on that risk is so important for informed decision-making.
Absolutely.
Now, what about mortality rates? What did the analysis tell us about that?
When it came to mortality, there wasn't a statistically significant difference between the groups. 9.1% of the EVT group died within 90 days and 7.4% in the BMT group. So it seems that EVT might not necessarily improve survival rates, but it doesn't seem to increase the risk of death either.
So it's a complicated picture, right? EVT for DMVOs, it doesn't seem to have a clear advantage in terms of functional outcomes or mortality, and yet it does come with a much higher risk of HISHREC. So given all of that, how should neurologists be approaching that decision of whether to recommend EVT for their DMVO patients?
I think that's where the idea of personalized medicine becomes absolutely essential. Now, this meta-analysis didn't just lump all DMVO patients together. It also looked at outcomes based on things like where the occlusion was and how severe the stroke was. Those findings give us some really helpful guidance for making treatment decisions.
Okay, so it's getting really interesting now, and I think this might be a good place to pause for a moment. Join us in part 2 of this deep dive as we really explore those specific subgroups and how we can tailor those EVT decisions for individual patients.
Looking forward to it. Welcome back to our deep dive looking into EVT for DMVOs. As we go on, let's zero in on those specific subgroups that the meta-analysis looked at, starting with the actual location of the occlusion. This is where things start to get a bit more nuanced, I guess you could say.
Right. Now, the paper did mention that they looked at different occlusion sites within that DMVO category. Why is that so important?
Well, the exact spot where that occlusion is in those smaller vessels, it can affect how well we can actually do EVT, and it might even have an impact on the patient's outcomes. This particular meta-analysis looked at the outcomes for three specific sites: the M2 segment of the middle cerebral artery, the posterior cerebral artery, and the anterior cerebral artery. And what they found was that, yes, the location of that occlusion really did seem to matter when it came to how effective EVT was.
Fascinating. So let's break down those findings, starting with the M2 middle cerebral artery occlusions. What did the data show for that group?
Okay, so for M2 occlusions, EVT actually did show a benefit. Patients were more likely to have excellent functional outcomes. That means an MRS score of 0 or 1 at 90 days.
Hmm.
But there weren't any big differences between EVT and BMT for other outcomes like functional independence or that CH risk.
So for this specific group of DMVO patients, EVT might give them a better shot at a full recovery, even if it doesn't necessarily improve their overall functional independence. Okay. What about those other occlusion sites?
Well, for the posterior cerebral artery occlusions, it wasn't quite as encouraging. They didn't find any significant differences between EVT and BMT for any of the outcomes they measured. That includes functional independence, excellent functional outcomes, ETA, or mortality.
So for patients with those posterior cerebral artery occlusions, the data doesn't really give us a clear reason to favor EVT. All right, how about the anterior cerebral artery? What did they find there?
Now, this is where things got a little, well, unexpected. In that subgroup, EVT was actually linked to worse functional independence compared to BMT.
Oh, wow.
It's a surprising finding, and it really underlines just how complicated treating DMVOs can be. It emphasizes how important it is to look at all the different factors for each individual patient.
So we can't just make a blanket statement and say EVT is good or bad for every single DMVO patient. The location of that blockage really does make a difference. And in some cases, like with those anterior cerebral artery occlusions, EVT might actually be doing more harm than good.
That's a really important point for neurologists to remember. Choosing to use EVT for DMVO, it shouldn't be based only on seeing that there's an occlusion. It has to be based on a much more thorough assessment. We have to consider the exact location of that occlusion.
Okay, so we've talked about location. The meta-analysis also delved into outcomes based on how severe the stroke was. This is really relevant for clinical practice because we often use those stroke severity scales to help us make those treatment decisions. So what did they find when they looked at stroke severity?
Well, this is where the findings get even more, well, I guess you could say complex. In patients who had a mild stroke, and that's defined as an NIH stroke scale score of less than 6, BMT actually led to better functional independence than EVT.
Interesting. So it seems like for patients with milder strokes, the less invasive option, BMT, might actually be the way to go.
It's certainly something to consider. And in that same group of patients with mild stroke, EVT was linked to a higher risk of ischemic. That just reinforces the need to be cautious with EVT in this particular group.
So it seems like EVT might not be the best strategy for everyone with a DMVO. Things like the occlusion site and the severity of the stroke, they can really affect the outcomes. How can neurologists take these findings and actually apply them to their everyday practice?
Well, and I think the big takeaway here is, like we were saying, personalized medicine. When we're faced with a DMVO patient and considering EVT, we can't just take a one-size-fits-all approach. We need to carefully assess each patient individually, taking into account where that occlusion is, how severe their stroke was, their overall health, any other medical conditions they might have. And this meta-analysis gives us a good framework to have those discussions.
There's a lot to think about. But before we move on, let's acknowledge that this meta-analysis, while it's valuable, does have some limitations that we need to keep in mind.
Oh, absolutely. No study is perfect, and understanding the limitations of this research will help us interpret the findings correctly.
Welcome back to Weekly Neurology Deep Dive. In this last part of our conversation about EVT for DMVOs, we're going to shift gears a little bit and talk about the limitations of the meta-analysis and what all of this means for stroke care, for research moving forward.
It's really important to remember that no single study, no matter how good it is, can give us all the answers. And this meta-analysis, it's no exception. Understanding where it falls short, where the limitations are, it helps us put the findings into perspective.
Right, and let's start with, well, the elephant in the room, I guess you could say. The fact that this meta-analysis relied heavily on retrospective studies. You've touched on that a couple of times. Can you explain why that's a limitation and how it might have skewed the results?
Sure. So with retrospective studies, we're dealing with data that was already collected. And often that data was collected for a different reason altogether, not for research. So the researchers, they don't have as much control over what's being measured, how the data is collected, all of that.
I see.
Now, in the case of EVT for DMVOs, that could mean there were variations in how they decided which patients got EVT, differences in the actual techniques they used, maybe even inconsistencies in how they measured those outcomes. All of these things, they can introduce bias, and that makes it harder to say for sure what's causing what.
So even though retrospective studies can give us valuable information, we need to be careful not to read too much into them.
Exactly.
It's kind of like, I don't know, trying to put a puzzle together where some of the pieces are missing or maybe they don't quite fit right.
That's a right way to put it. It really shows the inherent problems we run into when we're working with data that wasn't gathered specifically for the research question we're trying to answer.
Absolutely. Now, another limitation that the paper brought up was the fact that there wasn't a consistent definition of DMVO. Can you talk a little bit more about that?
Yeah, that's one of the tricky things about studying DMVOs. There's no universally accepted definition.
Hmm.
Some studies, they define it based on the anatomical location, exactly where that blockage is.
All right.
Others, they go by the size of the vessel that's blocked.
Okay.
And because there's no standardization, it gets really difficult to compare the results from different studies.
So even though they tried to account for that in the meta-analysis by doing those subgroup analogies like we talked about, based on specific occlusion sites, there could still be some variability within those groups.
Right, exactly.
And that variability, we have to keep that in mind when we're looking at the results, especially for those subgroups.
Absolutely.
So, given these limitations, what's the bottom line for neurologists? Should we just give up on EVT for DMVOs altogether?
I don't think that's the answer. I think the main takeaway here is that EVT for DMVOs, it's complicated. There's no easy black and white answer. What this meta-analysis really shows us is that we need a more, I guess you could say, personalized approach. We have to look at each patient individually, consider the location of the occlusion, the severity of the stroke, their overall health, all of that.
So it's not about saying EVT is good or bad for everyone with DMVO. It's about recognizing that the right answer is going to be different for different patients.
Absolutely. And this is where our clinical judgment really comes into play. We have to carefully weigh the potential benefits of EVT against the risks. We can't treat every patient the same way.
And this meta-analysis, it doesn't just have implications for how we treat patients today. It also points to some important directions for future research, right?
Definitely.
What are some of the big questions that need to be answered going forward?
Well, we need more prospective studies. Ideally, we need randomized controlled trials. Those would give us more definitive answers about what role EVT should play in treating DMVOs. And these trials, they should really focus on specific subgroups, taking into account the inclusion site, the severity of the stroke, all those other relevant factors we've been talking about.
I see.
And it's important to have long-term follow-up in these studies, too. That way, we can see how long any benefits of the treatment actually last.
It sounds like we still have a lot to learn,
We do.
but this meta-analysis has given us some really valuable insights that can help us guide our clinical practice now and shape how we approach research in the future. Any final thoughts before we wrap things up?
I would just encourage all our listeners, all the neurologists out there, to stay up to date on the latest research in this field. The evidence is changing all the time, and we need to be flexible, willing to adjust our treatment strategies as new information comes out. It's a really exciting time to be in stroke care. The more we learn about DMVOs, the better equipped we'll be to give our patients the most effective, personalized treatment possible.
This has been a really fascinating deep dive into the complexities of EVT for DMVOs. Hopefully you found it informative, insightful. Until next time, keep those brains engaged.